Good morning, everyone. Today I'll be doing a presentation on type 1 diabetes. The case study presented today is a 76-year-old male who has requested clinical exercise services due to his concern with his increasing body weight and fatigue when walking. Client X, which is what we'll call him for the purpose of this presentation, is a type 1 diabetic with hypertension and mild to moderate osteoarthritis. His diabetes is well managed with a continuous subcutaneous infusion, and he's also taking Avapro and Adalat Oros to manage blood pressure. He has presented to the clinic with the support of his wife and family and states that he remains social with his friends and is a non-smoker but does consume 3 beers per day on a regular basis. The overall goal for client X is to use exercise to manage diabetes and improve overall health markers relating to cardiorespiratory fitness and osteoarthritis. The short-term goal will be 10 minutes of exercise twice per day or 20 minutes in total, and after 2 weeks, increasing to 15 minutes twice per day or 30 minutes in total, 3 days per week. Long term, we're looking at meeting the minimum Australian guidelines of 30 minutes of moderate intensity physical activity 5 days per week. The clinical lab data provided is sufficient for us to be able to monitor and have physiological markers to aim for in measuring the effectiveness of the exercise prescription. Measurements from each supervised session can be recorded, as well as a follow-up appointment with a GP to adjust any medications according to any changes. Richard Sedergat and Cardenson in 2003 and Diabetes Australia 2021 show strong evidence that regular exercise helps people to feel in control of their conditions. This particularly relates to monitoring blood glucose levels, managing insulin dosing, adjusting diet, as well as other lifestyle factors. In relation to client X, the greatest benefit will be relating to improvement in cardiac function, as well as weight management, which has a positive influence on type 1 diabetes, as well as overall well-being. The case study states that client X is a well-managed type 1 diabetic. However, the lab data and initial subjective assessments of lifestyle habits show otherwise. This is supported because the data is presenting outside of normative for a 76-year-old male with comorbidities. His blood glucose, his fasting blood glucose, HDL, LDL, and total cholesterol readings, as well as blood pressure and BMI are outside of normative data. He is also currently not meeting the minimum requirement of physical activity for older Australians. Therefore, we must keep exercise intensity light initially as per the APSS-ESSA guidelines. All the other data presented was within normative ranges. To select appropriate exercises, further musculoskeletal strength and endurance testing would be required to apply a safe and effective exercise program and give markers to reassess the client's progress in terms of exercise-specific movements. Richard Sedergat and Cardenson in 2003 state that it is important for exercise to focus on the individual, taking into consideration diet, insulin dose, current fitness level, compliance rate, and availability. Based on the testing protocols for older adults, the tests have been modified based on lifestyle and current physical activity level of client X. To assess lower limb muscular strength and endurance more functionally, a timed get up and go test in which client X would be required to stand up out of a chair and walk 3 meters, then return to sit back down and repeat for 60 seconds would be conducted. For upper body strength and endurance, an arm curl test would be a useful baseline with low risk. And it can also be replicated as an exercise in the gym or at home. A foot assessment would also be a key component in assessing that exercise prescription and execution is not causing trauma or blisters. Regarding testing and exercise prescription safety considerations, we must be mindful of early autonomic symptoms such as sweating, tremors, palpitations, pallor, hunger, mydriasis, confusion, drowsiness, inappropriate behavior, speech difficulty, incoordination, and loss of judgment. Being mindful of these symptoms can prevent the onset of hypoglycemia, neuroglycopenic symptoms, as well as late onset of hypo or hyperglycemia. An accumulation of research has found that the training guidelines for hypertension are also safe and effective for individuals with diabetes or osteoarthritis. The ACSM 2010 guidelines for training individuals with osteoarthritis state that non-weight-bearing resistance training exercise is best suited to affected individuals if pain is present. However, if symptoms are managed, tolerable, and not causing functional impairment, then weight-bearing exercise is acceptable. The reassuring aspect of this program is that irrelevant of weight loss, which can be hard to achieve in older individuals, there is significant positive impact on hypertension and glucose control. The ACSM guidelines for exercise testing and prescription state that the contraindications for not starting or ceasing a test for type 1 diabetics is the same as healthy populations. However, special consideration should be paid to glucose readings prior, during, and after exercise sessions. For aerobic exercise, 7 to 10 millimoles per liter is optimal. For anaerobic exercise, 5 to 10 millimoles per liter is optimal prior to commencing exercise. However, this can vary, and the American Diabetes Association 2016 and Diabetes Australia 2021 state that 5.0 to 13.9 millimoles per liter is an acceptable target range prior to starting exercise. In relation to a higher blood glucose level, the presence of ketones needs to be ruled out. The exercise programs which have been written are taking into consideration the previously mentioned research. So the initial and home-based programs will be designed with 2 sets per resistance exercise with 8 to 10 reps, done with stationary bike intervals with 90 seconds rest between sets. Anaerobic exercise is to be completed at the beginning of the session, with aerobic exercise to be completed at the end of the session, prior to a longer cool down to avoid any complications. Keeping progression and regression simple and easy to apply to the individual who has low-level experience with training is a key component when dealing with client X. The progression and regression can be applied generally to the programmed exercises. So for the stretches, increasing or decreasing the stretch range of motion is a simple method which can be used. In relation to stationary bike, cadence can be increased or decreased to affect the RPE as a form of progression or regression. However, if the position of an upright bike in the supervised sessions is causing issues, then a recumbent bike has been shown as an appropriate substitute. The resistance exercises can be progressed by adding extra weight, reps, or increasing and decreasing the tempo. The exercises can also be modified by removing the isometric contractions, as well as removing the use of weight and simply completing the movements using body weight only or isometric contractions only. And with the isometric contractions, we must make sure that breathing remains normal to avoid any spikes in blood pressure. Research has found that older individuals who were given 3 home-based sessions per week using an exercise diary and a follow-up phone call for monitoring had the same adherence rate as older Australians who attended 1 supervised session and 2 home-based sessions. This is suited to client X, as he has expressed he would prefer a home exercise program and has the necessary equipment to do so. The initial exercise program will be 45 minutes in total so that we can minimize the risk of hypotension, syncope, and arrhythmias during and post-exercise. The weights selected have been applied for the purpose of this presentation. So here you can see a short warm-up, so consisting of some stretching, 1 set of 30 seconds with 10 seconds rest in between. And we've got instructions for each exercise of the program here and some images to go with that as well. The first lot of exercises here, we've got A1 and A2, which is done as a superset. So where you see A1, A2, or B1 and B2, that means that we do those exercises straight away, one after another with minimal rest. So we've got stationary bike and then standing calf raises with the prescribed repetitions here, and we've kept to those guidelines that we mentioned before with an RPE of 4, so starting quite light. We've got B1 and B2, so seated single leg extensions, so without using any weight, and get up and go squats with a 5-meter walk at an RPE of 4. C1 and C2, we've got seated leg curls and seated cable row. And then we've got our treadmill walking. Then here we've got hamstring stretches, calf stretches, and pec stretches to finish the workout. And that's a little bit of a prolonged cool down to make sure that we're avoiding any of those complications. So the final program, we've got the same warm up here. So just a little bit of light stretching for 30 seconds on each one. And then we have our stationary bike, which now we've taken out of that superset setup, and we've got a 60-second moderate intensity round with 30 seconds of light work at an RPE of 6 and 3, so slightly increased for that final program. Obviously, these increases will be supported by any subjective and objective data of the prior sessions as well. Then we've got some supersets again here. So standing calf raises with a seated leg curl. So this is a new exercise that we've introduced here. We've got seated cable row with weighted sit to stands. So now instead of doing that timed up and go, what we've done is we've added a little bit of weight to that sit to stand movement. And we've taken out the walking as we've increased some of the stationary bike and the treadmill walking at the end here. And then we've got isometric dumbbell side raises, and this is done as 3 exercises in a row. So we've got 5 to 6 RPE for the first 2 and an RPE of 4 for that last one. And to finish off, we've got some stationary bike. So 1 round of 5 minutes at an RPE of 6, and treadmill walking for 1 round of 10 minutes with an RPE of 4. And then a prolonged cool down again, so 2 rounds of that stretching. So this session should be about 55 minutes, given that the capacity and fatigue resistance of the client has also increased as well. The home-based program has been designed to be approximately 35 minutes with the option to increase resistance training sets as weeks progress and blood glucose control fatigue improves as well. So here you can see it is a little bit of a shorter program. And the other thing we've done for safety reasons is we've taken out any of those supersets so that we can make sure that monitoring of blood glucose levels is a little bit easier. So we're not rushing through any of those exercises. So A1, B1, C1, and so forth. And we've kept the RPE quite light, so an RPE of 4 until the client feels comfortable to increase that RPE a little bit. And then to finish off, we've got the same stretches for the cool down as well. So in regards to some of the unexpected circumstances, in regards to client X's blood glucose readings dropping from 7 to 5.5 to 6.0 millimoles after each session, research suggests that type 1 diabetics should know how to self-treat by following the Diabetes Australia guidelines, by ingesting 15 grams of fast-absorbing carbohydrates, such as jelly beans, then remeasuring blood glucose after 15 minutes, and repeating step 1 if needed. Under the guidance of a GP, insulin should be adjusted, if necessary, as glucose control may change with regular exercise. Regarding the second unexpected situation, research by Riddle et al. In 2017 suggests that if a hypoglycemic episode occurs after exercise, to ingest 20 to 30 grams of fast-acting carbohydrates. If after 15 minutes, blood glucose has risen above 4.0, but the next meal is more than an hour away, then ingest a larger carbohydrate snack such as a slice of bread or fruit. And monitoring blood glucose levels for 12 hours afterwards closely is important, as onset of hypoglycemia may occur. Regarding the final complication, check the ketone levels in order to rule out the possibility of ketoacidosis, and suggest that insulin levels may need to be adjusted by the GP, and check the timing of the last carbohydrate meal. If the carbohydrate meal was eaten within the last hour, this may elevate the blood glucose levels. The main point with programming for client X is that he needs to be given education throughout his sessions and follow-ups that exercise will help in relation to addressing physiological factors, as well as social factors such as time spent with family, as well as not feeling fatigued when walking his dog. We can also address the daily alcohol consumption for this client, as this may be impacting his medication and blood glucose levels, particularly regarding to these unexpected situations. So that's all for today, and thank you all very much for listening. Have a good day.